Once again to Dr. Humaira to introduce our next speaker of the day.
Okay, so moving ahead, our next speaker is none other than is Professor Senthil P Kumar, and this sir is Chief Instructor in AOMPT, Academy of Orthopedic Manual Physical Therapists. Sir is qualified MPT Musculoskeletal Therapy from Manipal University and having 18 years of post-PG teaching experience, including 10 years at Noida International University. Now, currently, sir is presently Director of Research at Bethel Medical Mission Group, Smith Hospital Education Institution under RGUHS, Bangalore for past 2 years. Sir has delivered 183 keynote lectures as invited speaker and presented 39 papers, research papers, and 19 first prizes in total 217 conferences held in 15 countries. He has published 257 peer-reviewed journal publications, focus at index and 7, and is the world's 13th most cited author on manual therapy with H index of 17 in Google Scholar. Sir has conducted 120 workshops in 18 states of India and a total of 610 webinars COVID-19 lockdown as a resource person. AOMT is the only academy with 7,000 plus followers on its Facebook page and rated 5 out of 5 stars for all its online courses by participants from 52 countries. He is also associate editor for Journal of Manual and Manipulative Therapy. So we all are very fortunate that we have Dr. Senthil Kumar with us. Over to you, sir.
On the screen, was it? No, the video was not muted or unmuted, something like this. It's really a pleasure to receive such a great and a generous introduction as I provided she introduced. Okay, so what is important here is the effort that has been put by the scientific committee and the organizing team to ensure that this conference reaches people from different countries and of course different disciplines and of course of different levels of participants, even students and also clinicians, or it could be researchers who might develop some ideas by listening to the experts. Pleasure sharing the platform with dedicated and passionate professionals and especially the organizing team led by Professor Simon sir. Noida International University and this AVANT GARDE, Recent Trends in Rehabilitation. This conference is a very unique theme, and I hope this session, what I am going to talk today, highlights you and gives you the importance of decision making in manual therapy. Manual therapy, the term itself, when you listen manual therapy itself, you'll feel like, wow, okay? It's the, what is called as the everyone's craze, okay? People want to learn, upgrade. They feel like identifying themselves as a manual therapist is better than identifying themselves as a physical therapist, okay? Of course, it's a subset of physical therapy. And then the next one comes to the certified practitioners, certified instructors. We have been listening to this in a lot of events that have been held around us, maybe workshops, maybe what is called as a certification courses. And we always see that this is the buzz of the town. And you see almost every day there are manual therapy courses happening all around the world. When you are talking about this decision making, I am going to highlight on a very important topic, which we may not have been aware. Okay, so I want to put a disclaimer first. So I will share a picture here for the disclaimer, and then we go to the presentation. And as I have my model, whose human model is ready, so then I can demonstrate some of the techniques to show you the difference between the two types of decision making, that is technique-centered practice versus patient-centered practice. So repeat, technique versus patient. So where is your focus? Are you focusing on the technique or you are focusing on the patient? Okay. So good luck to you all. Enjoy the session. We move on with the presentation. The organizers can interrupt me if there is any kind of a technical glitch. Dr. Humaira can inform if there is a video getting stuck or my audio is not clear, anything like that. And definitely participants will enjoy the session, right?
Sir, your audio is clear.
Video, I'm visible on the
Video
screen.
and audio don't clear. Video is visible and audio is also clear.
Yeah. Okay, when I am sharing the screen for PowerPoint or the presentation, I won't be able to see myself. Okay, so if I'm going off the screen, then you can immediately intimate me, right?
Sure, sir,
Especially when I'm demonstrating. If I'm
Sure,
doing a self-demonstration during the lecture. Demonstration on the model, definitely I will disable the screen sharing and then I will go here on the camera itself mainly, right? So we move on. I click share screen and then go to picture. Images. Right. So I want to extend this disclaimer. The contents of this presentation is solely of the presenter for the purpose of highlighting the importance of the topic and the clinical decision-making process, and is not intended to hurt any single person or organization existing or existed. The techniques demonstrated in this presentation do not represent actual techniques used on patients. So viewers must be exercising caution in using the techniques without formal supervised training. Any resemblance is purely coincidental and unintentional. Right? The disclaimer was clear, Dr. Humaira?
Yes, sir, it was totally clear.
Now, I'm going to share the presentation and we move on. How I have organized the presentation is to tell you about all the schools of thought of manual therapy. So we have many techniques in manual therapy, most of which was first they were clinicians, they were treating the patients, they got their own experiences, they saw that these techniques are effective and they developed it as a concept. We have Maitland's concept, we have Mulligan concept, we have Butler's concept, we have Siriak's concept, and they developed it as a concept. They're the experts. And these experts wanted to share their knowledge with everyone. So what they have done is, they have published textbooks, they have conducted courses, they have trained students under them. But however, after the experts have gone or they have become inactive, students have taken over the responsibility of spreading that knowledge all around the world. And some of these groups have also formed what is called as certifying organizations. So to maintain the quality of the instruction of each of these techniques, there are organizations that provides the license to practice and the license to teach. Certified practitioner, certified instructor. So in that aspects, they are trying to disseminate the technique all around the globe, as well as maintaining the quality of the technique as it was originally taught and practiced. So that is about the school of thought. So we have every Maitland concept is a separate school of thought. Mulligan concept is a separate school of thought. So we have schools of thought like this. Yes, that's the one side of the story. The other side of the story, we learned so much in theory. We learned so much in our undergraduation. We learned throughout our BPT. But when we come to internship and we are actually handling patients on one-to-one basis, people have given the responsibility that you have to treat the patient. Okay? You are the one who's in charge for this patient, like that. The intern is not able to apply any of these techniques which were taught into the clinical practice. And then there is a huge gap between what the training was given versus what happens in reality. It happens or not, okay? So definitely you should rethink what is missing here. Then the next thing, when we are treating patients, we follow a kind of a guideline. Okay? We follow a guideline like as our training happened. We know our orthopedic examination, right from history taking to all the histories it comes. And after that you see for subjective examination, then again it goes into length. And after that you see for observation, then palpation, then movement testing, then muscle testing, functional evaluation, special test, investigations, neurological examination. And then after that you frame a problem list, then short-term goals, then long-term goals, then the plan of management. When you listen to this orthopedic examination protocol itself, you feel like, oh my goodness, when I am going to evaluate this patient. And most of the times the undergraduates and the postgraduates, what they do is they do this in-depth evaluation only for case presentations. Because it is required by the faculty, students don't do it willingly, anything. And this extensive protocol is applied only for presentation purpose, not on routine basis. And then the next one, treatment. We are sticking to what we are familiar with, what we have been earlier using. And we see this patient when they come, he looks like that patient, okay, who came early. So we tend to identify the similarity in that patient. And then we treat it with whatever we know or whatever we were using. And after that, patient tells, I'm still having the pain. We have our own reasons to tell them that it won't be cured in a single day. Okay? So you had pain for 3 years. How will you expect one day it will go? So you come for 1 day. So we just postpone that. Most importantly, patient with knee pain comes to us and tells that I am not able to squat because squatting is paining in the knee. After treatment, the patient asks, can I squat? We tell them, no, not now, don't squat. Patient with the back pain comes and he tells that bending forward is paining. After treatment, the patient asks, can I bend forward? You tell them, no, not now, don't bend. Imagine, patient comes with the difficulty of not able to breathe in a pulmonary disorder. Will you tell them, don't breathe? What we are actually doing is not a treatment because we are just telling them to avoid an activity which is difficult for them. That anyway the patient can do. Why you should be as a therapist, as a physiotherapist, why you are needed. After qualification of 4.5 years, the instruction that is provided by the faculty in the college is not sufficient to make you actually treat the patient. Impossible. Definitely you can manage the patient. But what is the problem? There is a traffic jam. We think that we are not trained in the advanced techniques, so I cannot use those techniques. I have not got the certification in that technique, so I cannot use that technique. Right? And we also think in terms of what is called as whether my setting, the practice setting, they will allow me to use the technique. So what is our focus? Technique, technique, technique. Are we thinking that the person who is coming to us is a human being, same like me, who is having a symptom, a problem, which is a functional problem? So I should target the functional recovery. Not from the long-term goal functional recovery. I should start that functional recovery in day 1. First day itself, functionally, we have to treat the patient. If you see the evolution of research evidence over the years, the structure-specific treatments have been substituted by functional treatments. The best example is low back pain. The increased importance of aerobic exercise training, which is emphasized in low back pain, and reduced bed rest. And of course, if you are treating, remember one more thing, you cannot treat only the joints. You cannot treat only the muscles. You cannot treat only the nerves. Because in a functional activity, all 3 of them are working together. articular, myofascial, and the neural system, musculoskeletal aspects, components. All are working together. So if you have to treat or if you have to assess, you have to do together. So that is the most important factor which we have to realize. And another thing, original clinical practice was patient-centered. As I was evolving in the history of manual therapy itself, people used it on patients with their own freedom. Their creativity led to the development of new schools of thought. If we block that creativity, we are stopping the development of further new schools of thought. So what's important here is to realize that as with the evolution of mankind, we need to evolve the skills. And when we have to target the functional recovery, we should ensure that we improvise the existing techniques, we combine the existing techniques, and ensure that every time we keep asking the patient, are you getting better? Are you getting better? Are you getting better? Because patient-centeredness. And then we are not asking the patient, how are you? Are you better? Are you better? In order to find whether my technique is effective. Okay? I am asking him what he is feeling better because whether he is getting better. That means he can do the functional activity easily again. So that is the focus there. And although you might think that both are looking similar, but what is the difference? So we'll go to the PowerPoint and we can get on with the session here, right? So I will share the screen. Go to the documents, open the slide. Pardon me for the slide which is coming as 3 slides. Dr. Humaira, is it because single slide?
Yes, sir. Actually, 3 slides are showing together.
Because it's a PDF, I'm not able to do mobile view. I'm rotating the screen, it's not happening. Okay, pardon me for that. Okay, it might be a bit small in the presentation. I can understand that in the whole screen that all the 3 slides will be visible. Okay, if anyone wants to, I can zoom it as I am talking. Okay, so I can zoom it to section by section and then I can explain. Is it fine? This one is visible. First slide, if I'm zooming.
Yeah, yes, sir. This is visible, but half of the slide we can see.
Yeah, half only. When I go to the right side, the other half will be visible.
Okay, sir. It's totally fine, sir.
Yeah, because I don't want to show all 3 and
Yes, sir.
it will affect the visibility totally. If I'm showing one full slide, all 3 only will be visible.
Okay, sir.
So I'll go to first anyway the slide will be there. People can take a screenshot if they want. And after that, as I go to sections, I can talk about this. Okay.
Yes, sir.
First and foremost, what I want to actually tell is the technique-centeredness and the schools of thought by many experts have all been maximally developed outside India. So as an Indian or from any country, think of developing your own techniques. That is the first take-home message. And the second thing, of course, this lecture is my 184th conference lecture. And that's my WhatsApp number. You can note down. The topic is manual therapy and rehabilitation, technique-centered versus patient-centered. In the conference organized by Noida International University, AVANT GARDE trains in rehabilitation. So we have techniques, and that is about my details, my website, Academy's website, and the Facebook link. When we are saying for the manual therapy, the schools of thought, okay, the history and philosophy, and we can group the manual therapy into impairment-based manual therapy. That is articular impairments, joint, capsule, ligaments. They're related. Ortho manual therapy. Myofascial impairments, muscles, fascia, tendon, myomanual therapy. Neuromanual therapy, it's for the nervous system, central or peripheral. Pain and also what is called as different types of neural pain is there. We'll go into that slide. And then we have the case example with the practical demonstration. And I'm going to introduce you to a technique which is combining the articular myofascial and the neural, which is a registered technique of the AOMPT called as the orthomyoneuromanual therapy, where we are not focusing on the technique because we are combining all the techniques. I am not bothered about whether mobilization is better or myofascial release is better for this patient. No. I gave a treatment and the patient became better. Okay, so the focus is on patient-centeredness. So that is what we are going to see. Coming to the history and philosophy, remember the left side has the names of the founders of each of this technique. The rest of the sentence tells about the actual technique description. Brian Mulligan. I have not arranged these names in alphabetical order. I have arranged only articular, myofascial and neural and in the sequence of clinical evaluation and treatment. So Brian Mulligan's mobilization with movement techniques for dynamic positional fault in functional positions. So that means there is no abnormality at rest. The abnormality in the joints alignment comes in movement at the end of the movement and coming back, there is no pain. Okay, so that's the first indication. And Jeffrey D. Maitland, passive mobilization techniques. We are aware of these glides and also the passive movements as mobilizations for static positional fault. That means you are finding a joint that is out of place even at rest, excessively anteriorly glided humeral head. And then you are evaluating the flexion of the shoulder and you find a restriction of the flexion. You know that anteriorly glided humeral head will not allow the flexion. You need the posterior glide. So you can evaluate the posterior glide and then see for whether it is the pain or it is the resistance which comes. Like patient tells pain, it is the pain. If it is like a stiff sensations, tissue stretch, you know that it is the stiffness or the resistance. So depending on that, you can give grades of mobilization, grade 1, 2, 3, 4, the 4 grades. What we do in the grades of mobilization is small amplitude rhythmic oscillatory mobilizations given in the beginning of the range is grade 1. Large amplitude rhythmic oscillatory movements produced in the beginning of the range is grade 2. Large amplitude rhythmic oscillatory movements produced at the end of the range is the grade 3. And the last one, small amplitude rhythmic oscillatory movements performed in the end of the range is grade 4. So that means grade 1 is also small amplitude, grade 4 is also small amplitude, grade 2 is large, and grade 3 is also large amplitude, right? And what we have here is, in the pain pattern presentations, we give grade 1 and 2 mobilizations, whereas the resistance or the stiffness pattern, we give the grade 3 and then progress it to grade 4 mobilizations. That is about the Maitland concept. Robin McKenzie, he described about mechanical diagnosis and therapy for postural dysfunctions and derangement syndrome. So 3 categories of the patients types. We divide them into postural syndrome, dysfunctional syndrome, derangement syndrome, and then we treat them by modifying the posture, either in a flexion or an extension direction, and giving passive forces in addition to that. Brian Edwards is another Australian physiotherapist. McKenzie is from New Zealand and Maitland is Australian, Mulligan is New Zealand. So Australia and New Zealand was the foundation there. Brian Edwards, he told about combined movements. So you don't check only extension and flexions. He said that extension with lateral flexion you have to check. And some patients might require extension plus lateral flexion plus rotation, either to the same side or to the opposite side. Okay, so you can evaluate various combinations of movements and identify the patient type who require combined movements as mobilizations. Okay? When you talk about the European orthopedic physician, who is James Reax, he mentioned the importance of active movements, passive movements, and rested isometric tests, which 3 are combinedly called as selective tissue tension testing. And next is, he said, soft tissue injections. So we can inject with steroid injections directly to the tissue. Deep friction massage we can give. And of course, the manipulation techniques, the loose body manipulation techniques, or also the adhesions. To break the adhesions, we can use manipulation techniques for soft tissue injuries. That's about the articular, the 5 concepts: Mulligan, Maitland, McKenzie, Edwards, Reacts. Next comes the myofascial, the 4 concepts. That is the Jones positional release technique. Okay, and what we do actually, positional release technique is for the muscle spasm, which usually comes in active myofascial trigger points. Okay, when you palpate, it might give a effort pain, and the patient comes to us with pain. Whereas the myofascial release techniques were explained by John Barnes, and it is especially given for adhesions. So if there is muscle fascia, there is an adhesion, because of which muscle is not able to work. So what they do is glide the fascia, release the fascia so that the muscles can work normally. So myofascial release techniques. So that is given for adhesions in myofascial trigger points. Fred Michel extended it to a next stage. Many of them are osteopaths. If you see Jones, Barnes is a physical therapist plus osteopath. Michel is an osteopath. Muscle energy techniques we can give. For example, if there is spasm this side, I can give reciprocal inhibitions, opposite side muscle contraction, so that reciprocal inhibitions. Or if it is tightness, I can activate the same muscle, lengthen the muscle, again activate it 5 times. After that, again lengthen the muscle. Because activation of the same muscle with isometric contraction will induce the relaxation and lengthening of the muscle. And the contractures and isolated contractions are rarely used nowadays. Comerford and Mottram from UK, the physical therapist, they have evolved the kinetic control approach, which is basically extension or improvisation of motor control retraining. The previous speaker, Dr. Nidhi, was talking about the role of stabilizers and the static stability, dynamic stability for scapular and glenohumeral. So all this is for the muscles which are lengthened and they are inhibited. So you want to activate them, and so that the movements will be energy efficient and it will be smooth. David Butler, neural mobilization. What he published first as the mobilization of the nervous system and upper limb tension test, the nerve tension techniques. That is a combination of joint movements which involve elongation of the nerve bed, the muscle supplied by that particular nerve. And nerve massage, you can palpate the nerve and then you can also give massage. So as explained by David Butler. Michael Shacklock, his prodigy, immediate junior, he explained about not just elongating the nerve, we can slide the nerve. So that means we are not actually producing a tensile force. If we are producing a tensile force distally, we can offload here proximally. If we are producing the tensile force proximally, we can offload distally. So that the nerve will be sliding instead of tensioning. Okay. So the 3 specific impairment strategies are articular, myofascial, and neural. And we can go for the various identifications. You can see here, I have mentioned the structures before. When you are examining the joints, examine by compressing the joint, examine by distracting the joint. When you compress, intra-articular structures you are checking. Okay? And when you distract, extra-articular or peri-articular structure, capsule and ligaments you are checking. Okay? Muscles, you are checking by contraction. And you know, concentric contraction is for the muscle belly, eccentric contraction is for the tendon. And when you are palpating also, you can palpate the muscles. You can elongate the muscles by the joints that they are crossing. So you can move it in the opposite direction and you can stretch the muscles also. Fascia, you can check with the facial play. So if I have a trigger point in the masseter, I can do the facial play on my cheeks. So I can assess neural, I can assess by Tinel sign. Okay. So I can easily evaluate the compression of the median nerve in the carpal tunnel. Okay. And the next one is of course neurodynamic testing, which I was demonstrating here, previously called as the tension test. Okay. So now at this stage, I wanted to emphasize now that I'm going to do a practical demonstration. So I'm going to stop the screen sharing. Come on the camera, right? as our model, Mr. Gautam has come. Okay. Right? Are we clear here? Dr. Kumara is visible? Myself,
Yes, sir. Yes, sir. You are visible. Your subject is also visible.
Continuing with the demonstration. What's important here first? I'm telling you a case example. Okay? He's a young boy. He's a studying computer engineer. Okay, so he's a don't assume every computer engineer will be like having symptoms with keyboards and things. Recreationally, he plays tennis. So whenever he plays tennis, earlier he was fine, but now recently for past 1 week, he's feeling like a kind of discomfort. If I ask him to come to standing and demonstrate the tennis serve, okay, so tossing the ball and then tennis serve, so that movement is complaining of pulling pain in the dominant side, okay, pulling pain which comes in the anterior arm and to the forearm, right? So that's the situation here for Gautam. So that means the major pain is a pulling pain. And this pulling pain makes him feel like fatigued, okay, tired. And after that, he's not able to perform to the highest level of his potential. And unless he stops the game, the pain starts becoming more severe here. Okay, if he continues with the game, the pain becomes more severe here. And after that, he cannot touch this area also. And he has to keep on holding this region. Okay, so he has to hold it, and only pain becomes less. And in the past history, when I'm asking, he's telling that morning when I wake up, I feel my neck is not that much free. Okay, so what I do is I just turn the head and then I will give a thrust, okay, which we always do. And after that, we feel like the clicking sound comes, and then he feels he's normal. Okay, so this is he is doing right from childhood. So that is something which he does. So this is the presentation history. And how old is he? 20, 21 years. This patient, if he takes an X-ray, will show normal X-ray, absolutely, because his bones are normal. And then the next one, if you have to treat this patient, right? If you are a technique-centered orientation, what will you do? So that is the demonstration which I'm going to show now, right? So I'll ask him to relocate as I shift the camera towards the plinth. Yes. Good. Right. And yes. Pardon me for a moment. So now I know that it is the arm movement fully. This section of this demonstration is really not a scientific or the professional method of instruction. Okay? So as I mentioned in the disclaimer, so I am highlighting this. So I go off the screen and then I'm going to come back as certified Mulligan practitioner, right? Who am I? Certified Mulligan practitioner. So I know that I have to give mobilization with movements. What are the mobilization with movements? Mulligan has told you can give glides as part of the functional activity, right? And the glide is reducing that pain in the functional activity. Definitely, that glide is indicated for the treatment. So he was the one person who said about functionally treating the articular system. So I might ask him to take the arm into the serving position, okay, the tennis serve, the overhead elevation on the tennis serve, that position. And I will ask him, are you having the pain? He will tell, no pain. Okay? Because when he plays tennis, only the pain will come. Now the pain will never come. Okay? He said, after playing for half an hour, then the pulling pain comes. Okay? So he's not going to have any pain now. right? So take your hand up. Do you have pain? Okay. But still, what I do is, anyway, I have to give mobilization with movement. So I will give anterior glide to the humeral head. Okay, and take his arm down. Again, take it up. Again, take it down. They will tell nothing is happening. Okay, because there is no pain reproduction. Okay, and if pain is there, then I can keep that whether it is reducing with the glide compared to without the glide. And then after giving 5 repetitions, he asked me, okay, what is my problem? Okay, and I tell there is some problem in your arm. Okay, but the joint is going out of position when you are playing tennis. Okay, I have actually corrected the joint position now. Okay, so definitely next time when you play tennis, watch it and come and tell me. Okay, are you getting better? Okay, I tell like this. So this is because I am a certified Maligan practitioner. So I have supposed to do only the mobilization with movements, and I follow the protocol or explanation given originally, and I give the treatment without even seeing that the symptom can be neural, right? The pulling pain or the myofascial spasm which the subject might have been having when he continues the game, and with a whole history of clicks in the neck, instability, articular. All these are sideline. This is what happens. Next practitioner, we're going to see now. Certified Maitland practitioner. What are we actually going to do now? Because I know that mobilization should be given, passive mobilization, and subject should be treated with physiological movements or the accessory movements. Okay? Physiological mobilizations or the accessory mobilizations of the glides. So what I have to do is, I will make it to change the direction. And first, I will check the neck movements. Why? Because if I have to give joint mobilization, articular system has to be examined. But his problem is pulling pain in the arm. That is first symptom. Okay, he has come to us for that. So he will always tell, my arm pain is there, pain is there. Okay. So that is what his concern will be. But what I will do is I will examine the flexion. I will see for segmentally how the mobility is. Okay. And after that, I will examine the lateral flexions. Okay. Here also segmentally I will differentiate how it is, okay, which level laterally it is flexing or not flexing. And then I rotate the neck and then give the overpressure. In this also, segmentally I will differentiate the rotations. Okay. After which, throughout this, he does not tell anything abnormality in the neck. Then I can glide the scapula and evaluate. Okay. I can do the shoulder evaluations. And then finally what I do is, I might ask the subject to what is called as lie down. So once the subject is lying down, I can go to the shoulder. This is elevation. So for improving the elevation, inferior glide has to be given. Okay. So what I can do in the dominant side is slightly abduct, keep the arm, give the inferior glide. Right? Is another thing. I can also give a posterior glide because he is doing the flexion of the arm. I have given in lying down position because Maitland tells mobilization has to be given in relaxed position. You cannot give it in sitting. Mulligan told you can give it in sitting, but it is not reproducing the shoulder. It's not articular symptoms of the shoulder. It is neural. So now, after this, I ask him how is the pain. What you are expecting the patient to tell? I will get the pain after playing tennis, not now. So patient will tell the same answer. I will tell that the same reply. You go, play the match, tell me how do you feel, and then come back. I'm giving only this to you. The third is I am a certified myofascial release practitioner. So myofascial techniques. He is telling what is the problem? You said pulling pain. Don't worry. This pulling pain comes because there is compression of the nerve by the muscles. I immediately get into a jumping conclusion that muscle is always important because I am a myofascial release therapist. So muscle is important. So myofascial spasm. So he's not allowing me to palpate. Okay. So what I can do is I can do a positional release technique. Keep the spasmodic muscle in the shortened position. Palpate it for easiness of the tension. I can also give reciprocal inhibition so that the spasm will be reduced as per the muscle energy techniques. And then afterwards, progressively, I will release the muscle, specific myofascial release as the spasm has reduced. And finally, I can go for the direct release, which is through the ischemic compression. Okay? So that is the protocol. Because myofascial release tells that okay, this is the thing which you have to follow. So I get that. He tells, I'm feeling here, neck it is very loose. Okay, I'm feeling good. But I don't know, that arm that I used to feel heaviness like that, or that pulling sensation, what will happen? I will tell, I have treated your muscle. You go and play, definitely the pulling pain won't come. So I am getting the patient to focus on whatever I have given. I am treating only whatever I know or what I have been trained for. I am not saying what is exactly the problem with the patient. Okay, so this is the second category, myofascial practitioners. Third practitioner, neural. I am a certified neurodynamics practitioner. And I know that pulling pain is neural. Yes, I got a patient to use the neurodynamics. So I will evaluate the upper limb neurodynamic test. So I take it, abduction, external rotation, wrist extension, supination of the forearm, and elbow extension. And he's telling that pulling sensation is there. And then what I will do is, if the sensation is in the end range, I can do a slider. If I am trained by Michael Shecklock, I will use the sliders. If I am trained by Butler, tension techniques, I will use tensional techniques, grade 1 mobilizations, grade 2 mobilizations, and grade 3 mobilizations, and 4 mobilizations. The same grades of Maitland is the neural body positions. After which he tells that arm is actually better, but here I am feeling it is hard. Okay? This is what he will tell because he gets the spasm there. So then what I do is, I tell him one thing, the familiar answer, what every therapist gives, techniques and therapist, is I have treated the nerve. Remember, the nerve is supplying the muscle. So I have treated the nerve, so muscle will become normal itself. I am ignoring the component that there was clicks in the neck. R is what spasm, release continuing the head. That ends the story here, the techniques and practice. Right? Now we are going to go on to the next section, that is the patient-centered practice. I'm going to show the demonstration now. Enjoy this. In patient-centered practice, what do we actually do? I identify that there are impairments which are combined impairments. There is neuro, there is myofascial, and there is articular. So what I should do? Articular I see first. Why? Because it is clicks, it is instability. Stability should be first for every functional activity. Okay? So I give a good counseling that why he is actually doing the thrust technique in the mornings. Okay? And I should explain him that instability of the spine, cervical spine, will not enable the upper trapezius to work properly. or the neurodynamics of the brachial plexus. So the nerve may be getting abnormal dynamics when he's actually working during the tennis play, especially during the service or the overhead return shots or even the smash. So what happens here is, I explain that, and then I tell him one important thing: to take the chin back in a rotational motion. I'm activating the deep cervical short plexus, the stabilizers of the cervical spine. And if he is having difficulty, I can use the pressure biofeedback device to train that subject can do this. And most importantly, breathing. I will tell him to do longer inhalation if the restriction pattern of chest expansion is there, or the longer exhalation, first lip, if the obstructive pattern of chest expansion is there. Why? Because we are expecting all patients to have either recovered from COVID or they are having COVID inside, but there is no symptom. Trust me, amongst all of us, there is nobody who is a COVID patient. There is nobody who is a normal, because the virus is inside every one of us. There is a symptom not there, the test is negative. There will be a moment when the test will be positive. When the immune system goes down, the virus will take over. This is the situation what they are doing, the new normal. So patients who come after the COVID and admission and discharge, you should treat the breathing pattern retraining. It's very, very important that you treat musculoskeletal in combination with the cardiopulmonary. Patient is not going to sit and sleep. He's going to do the breathing exercises. I will even ask him to take the tongue to the hard palate, then keep the jaw closed, then do the deep cervical flexors endurance, go to the position, so that the stabilization of upper cervical will be together with the mandible, and definitely it is functionally very, very useful. And during this placement of the tongue and the contraction, he will keep breathing longer inhalations if he is having a restrictive pattern, which is much more common. Okay, why restrictive patterns are common? Because most of us don't do the deep diaphragmatic breathing. Unless there are smokers who will have what is called as the distal emphysema, these kind of pictures, the alveolar walls will be enlarged and the air trapping will be there distally. They will have difficulty with exhalation. Right? So, they will have the wheeze and all. So, this is I am giving this. This is the first thing. So, he's holding this position, articular, right? And this is stabilization, that is primary. Next is this side spasm. This is the dominant side upper trapezius. This is upper limb, which is actually we use it for the service. And what I'm going to do now is, first, as I train the cervical spine stabilizers, next itself I will ask him to keep the arm in the service position or the overhead position, the tennis. And if I have a tennis racket, I will even give the racket, because weight of the racket functionally will mimic. And I know it's coming after half an hour of play. So holding it for 2-3 minutes, it's not going to worsen or produce any disastrous clinical emergency. Okay. So in this position, stabilization is important. So tongue and the deep cervical short plexus and the breathing. And next is, here there is spasm. So what I can do, give reciprocal inhibition, asking him to push this side. Simultaneous. He is doing the stabilization for the articular component for the clicks. Okay? And at the same time, I'm giving reciprocal inhibition. Myofascial. Right? So articular, then myofascial. And here, neural is there. Okay? So what I can do is, the arm position, I can keep the neck to be pressing on me, okay, for the reciprocal inhibition on my chest. If there is another therapist, they can always do simultaneously by another assistant. Okay. And next is, so this is one. So here I am demonstrating with my chest. He's doing the stabilization and the breathing, and he's also giving the pressure on my chest. Okay. And next, what I can do is adapt with elbow extension, abduct with the elbow flexion. Repeat. I adapt with the elbow extension, abduct with elbow flexion. Why? Because abduction and the extension is loading and it is creating the tension effect on the nerve. I am doing a slider, nerve slider, with reciprocal inhibition, with the stabilization for the articular component. All the three. guess the difference between the technique-centered practice versus the patient-centered practice? Of course, I hope the participants were highlighted on this. What's important here is to recognize the fact which is the priority. Okay, whether articular is priority. I took the articular as priority because instability is priority. If it was stiffness, old age, degeneration, crepitus, restriction of movement in the neck. I had neck pain for 6 years, 50 years, old man is telling me. So then my priority will go to mobilization of the joint rather than the stabilization. If it was clicks, I should know that it is instability. And myofascial spasm, it comes in the middle, okay, in the activity which is provoking also, and treatment also you can use it in the middle. So that if interface is prepared, nerve can, interface means the structures that is next to the nerve. If that is relaxed, nerve can actually efficiently move. And why did I give sliders? Because sliders are always safe to give on day one. In good progressions, we can do the tensioner techniques where we might do abduction with extension. Okay, so like this I can do, right? So this I can progress to this also as the spasm has reduced. Okay, so what I have done is simultaneous application of all the three techniques, articular, myofascial, and neural. And if the subject has told that now itself I am having spasm, okay, and he is not having the pulling pain, now he is having the spasm, okay, then what I would have done is first is reciprocal inhibition because he is having presently spasm, right? So first is reciprocal inhibition and then motor control, breathing, right? Second, and then just put down, just okay. So first is reciprocal inhibition because the primary presenting spasm is there. Okay? So I have to release the spasm first, relieve the spasm or calm the spasm, optimize the spasm. So I can ask him to push. First is reciprocal inhibition. Next is deep cervical flexors and endurance and breathing pattern retraining. And the last will be the sliders, as I was demonstrating elbow flexion with abduction, elbow extension with adduction or the inversion, right? So the sequencing has changed now. Another, if the patient is telling that now itself I am having pulling pain, right? So what will be my primary thing? Neural. I should not concentrate on myofascial. So here for this situation, what I will do is keep the nerve in the mid-range loading. Okay. I will not keep it in the end range. So just to keep it mid-range loading with the wrist extension, external rotation, and in the mid-range loading of the nerve, where the pulling pain is not provoked, after the neural, I will give for the spasm, reciprocal inhibition, push. So myofascial spasm, second one. And the last will be the deep cervical flexor endurance, which is chin, tongue, okay, and breathing. Okay. So the sequence of using articular first, myofascial first, or a neural first depends upon the patient's clinical presentation, not depends upon my training, whether I am a certified INR treatment or the certified myofascial or the certified neural practitioner. What's important here is patient. What is the exact presentation in him? If it was past history, right? What is it today? That's important. And then I combine these two. This approach is of the AOMPT, and online training is always available because of this extended lockdown. So ortho, bio, neuro, manual therapy, it's a functional approach where we combine all the three major categories of parameters, articular, myofascial, neural, to benefit the patients. Okay? This is an example to show you what is patient-centeredness. Okay? So we are going to continue with the slides, and then we are going to have interactions. Yes. Dr. Humaira, so far so good?
Yes, sir. It was really good, informative, and we really enjoyed your session. And
yes.
I
I'll go
hope
to the
I hope everyone
point.
has learned. Yes, sir.
Slide is there for another 10 minutes.
Yes,
Are
sir.
we on time?
Sorry, sir.
Are we on time?
Yes, sir.
Slide will go for another 10 minutes.
Sure, sir. Sure, sir.
Yes.
I'm looking forward to learn more about you, sir. You can continue, sir. Please.
Prapurva, can I see you on the screen? Been a long time. I never, we didn't get an opportunity to see directly. If this conference was a direct conference, definitely we would have met. Can you come on the screen? Is it possible for you? Video unmute. Sure, sure. Because you are the best example of a person who is inspiring. But it's doing a phenomenal work of leading this team. Very much, sir. Keep rocking. Yes. I believe that you look the same. I have put on a bit of weight. So, right? Good luck to you and good luck to the team and I for holding such a successful presentation. Dr. Mara, ending with the screen sharing, the similar PDF. Yeah, yeah. So go on to the screen sharing. To the video. Yes. Right. So basically the articular techniques, you know, the McKenzie is for postural abnormalities. Maitland is for passive movement abnormalities. Mulligan is for and functional abnormalities, but they're treating only the articular system. Edwards is for combined movements, and Syriac's technique is for loose body manipulations, where we give rotation with this. And you know, articular trauma can relate to degenerative disease, stiffness that eases movements. Macro might lead to a sprain, tear in the capsule, instabilities. Symptoms can be stiffness, clicks, crepitus. Stiffness will indicate high mobility, clicks will be hypermobility, crepitus will be. So when we talk about the experts for myomanual therapy, the myofascial techniques, there are various people contributed throughout the years. The positional release, myofascial release is indicated for other people. This is as ischemic. If I have a trigger point in the flexor pollicis brevis, the thinner muscle, after texting. And after this, of course, muscle energy technique, which is reciprocal inhibitions or the relaxation, okay? And the motor control and the coordinating. And of course, here also macro trauma and micro trauma can get into the picture. Usually the myofascial pain comes at the end of the day. Usually the subjects have arterial circulation to be impaired, or it can be due to temperature also. Cold temperature will aggravate the myofascial pain and warmth will relieve the symptoms. Diffuse the aching pain after overuse, typically. So neuromanual therapy, again the neural techniques have been in evolution over the years, and the different approach of neuromanual therapy is a combination of neuromobilization and neurodynamics and integrating the myofascial and the articular techniques, but prime focus is on neural symptoms. It's an indigenous approach of the AOMPT, neuromanual therapy. So a combination of injuries and symptoms, you can see types of neural symptoms, numbness and tingling versus pins and needle, radiating pain, or the pulling pain, which I was demonstrating in the patient, versus hand scrolling could be due to autonomic dysfunctions. So in technique centeredness, basically what is happening, unfortunately. So here, the first top of this, so I'll keep it in the center. The evaluation and treatment is as per a validated protocol and format. Technique precision and parameters are given more importance. The therapist usually asks how many repetitions, how much pressure, okay? How many times in a day. More about the prescription. We are selecting the patient for the technique. Okay, so patient is suitable or not, then we are applying the technique. More concerned is about the effectiveness of the technique. Certified practitioners or instructors only are licensed to use and then disseminate it. Okay, instruction is focused on the technique options, but not based on the patient disorders. So if I am a certified ABC practitioner, if I am asking a question that how can we use ABC in cervical spondylosis, they will say these are all the techniques for the cervical spine and you can use it. They will not tell what happens in cervical spondylosis. Okay, so that is what I am trying to highlight here. In short, technique centeredness makes us technicians. So some of the pictures for the techniques, articular techniques like mobilizations, myofascial techniques like releases, and neural techniques like tensioners and sliders. Patient-centeredness, what happens? Evaluation and treatment is as per the clinical presentation and the functional demand. Patient responses are given more importance. Select the suitable combination of the techniques, okay, for application on the patient. That means we are selecting the techniques for the patient rather than selecting the patient for the technique. More concern is on the improvement of the patient. Any practitioner or instructor can use it. You can see the slide above and slide below, okay, for the technique and the patient-centeredness. Instruction is focused on clinical patterns of disorders and not based on strict rigid protocols. So it mimics the reality. In short, patient-centeredness makes you clinicians and makes us clinicians. So this is about the arthro-myo-neuro manual therapy. It's a simultaneously integrated patient-centered application of all three manual therapy impairment-specific techniques as a single standalone technique within the biopsychosocial clinical approach. So again, that principles of articular and myofascial neural. This is the example, the same which I have demonstrated on the subject. Okay. So in reality versus therapy, you can see that in reality, structures from multiple systems work together and symptoms become important only when functional limitation arises. The subject comes to us because he is having a function. So don't treat them structurally. Okay? And functional evaluation is essential for identifying the dysfunctions. Problem-oriented integrated therapy is important. Functional limitation is different for different individuals. My right arm and left arm itself is totally different. Because this is non-dominant, this is dominant. I have more external rotation on the dominant side. I will have more internal rotation on the non-dominant side. Okay? So there are a lot of differences which are due to nutrition, lifestyle, physical activity, and personal habits. Incorporating mechanism-based reasoning, that's another higher level of decision making, where we identify the patient into cognitive affective central sensitization, which is nociplastic pain. And then the next type is peripheral sensitization, sympathetically mediated pain, and the last is nociceptive pain. The 5 categories are there. what I would request the participants and the viewers is to get the importance between the technique-centeredness and the patient-centeredness. Basically, it is the combination of techniques. Basically, it is the functional re-evaluation of the patient. Okay? And then incorporating mechanism-based reasoning into a functional approach will individualize the treatment, because you should not treat the similarity between the patients. You should treat how this patient is different from other patient, treat that difference. Then only you will make a difference in the patient's life. Noida International University. Yes, that's about our memories which we had in INCPT AIMS. You can see here the two dynamic leaders of SONHS and NIU and the faculty who were present those days. Association with Professor Naveen H. Simon sir has been 4 years, even before I joined NIU. And it's always great to have people like him around who values other people's potentials and acts as a mentor, as a friend, as a guide, as everything that you can expect the best as a human being. He is the one person who really lives God's blessings. He transfers to everybody around him. So really, it's a great pleasure to be associated with this conference. And of course, all the gratitude goes to the present Vice Chancellor and the former Registrar, our Professor Jayanand sir. So he's the one who definitely has been a strong support. Even after I left NIU, he's still in touch, and he's really great to allow and permit this conference and also give his talk yesterday. So he's a great inspiring role model. So of course, we have come to the last slide. Note down my WhatsApp number. I can send you the slide on it. And the courses of AOMPT, you can always enroll. You are welcome to join AOMPT as life members, and you will know how your life has changed before AOMPT and after AOMPT. So that's about the final words. I can close the presentation, get back to the camera. Right. Yes, Dr. Vinda.
Indeed, sir, it was a wonderful session. We have learned a lot from you. And unfortunately, I have joined NIU when you left the NIU. So for me, it is a great opportunity that I am able to talk with you and I am able to learn from you. Thank you so much, sir. Thank you so much.
I didn't want to tell you that I actually worked in NIU, okay? When you have communicated with me in the beginning. Okay? Participants, please feel free to put your questions so that Dr. Humaira can read out and raise it for the interaction. But you made one kind of a pleasant error. During the introduction, you said I worked 10 years at NIU. Okay? But still, I didn't mind that because I worked nearly 10 months, but it was equivalent to working for 10 years. Okay? Yes. Such kind of a rich experience and values and excellent people around. So it's a beautiful place. I really wish all of you the best of luck and keep inspiring. Right?
So, participants,
do we have any?
Participants, if you have any query, then please write it down in the chat box.